Hello, everyone. My name is Dr. Amit Mehta. I'm a hematologist and oncologist in Cary, North Carolina at Premier Hematology and Oncology, and previously on the faculty at Duke University. It's my pleasure today to be joined by Dr. Asad Dean, a hematologist and oncologist and also medical director at Texas Oncology, who's going to tell us about a patient of his with immune thrombocytopenic purpura that was treated with a BTK inhibitor indicated for ITP. The title of our series is called Exploring Multi-Immune Modulation in ITP and an ITP Patient Case Review. So a few disclaimers as we begin. This video is for healthcare professional or HCP use only. This video is sponsored by Sanofi. Speakers have been compensated and or received an honorarium from Sanofi in connection with this video. The content contained in this video was developed by Sanofi and is not eligible for continuing medical education or CME credits. Results may vary. Results from one case study are not necessarily predictive of results in other cases. This is also a very good chance to highlight some of the evolved understanding of immune thrombocytopenia pathophysiology. We've known that there's B-cell-driven autoantibody production that drives an antibody attack on the patient's own platelet cells, resulting in severe thrombocytopenia. But in more recent years, we've learned that there's a much more complex immune dysregulation occurring in ITP pathophysiology. So with that modernized understanding of ITP pathophysiology, we're going to take that information and think about that as we hear about a real-world patient case by Dr. Dean with immune thrombocytopenic purpura.
Thank you, Dr. Mehta. I am delighted to be with you today to share a patient case with you and my colleagues. My patient is a 51-year-old female who has a history of hypertension and obesity and is also on estradiol. Her activities are limited, particularly her exercise, due to fatigue. In May of 2025, she had presented to the hospital with approximately a 1.5 to 3 week history of easy bruising. On complete blood count, her platelet count was 8. She had a normal hemoglobin at 13 and a normal white blood cell count at 6.
So in this patient's case, Dr. Dean, the platelet count clearly went down quite significantly. And in addition to the platelet count itself, what were some of the key clinical factors that were concerns of yours in terms of how you're going to approach the next steps for your patient?
Well, medically, she had a history of hypertension and she was also on estradiol. We know that estradiol can be a risk factor for thromboembolic complications. And the other interesting thing that she had shared with me upon inquiry was that she was fatigued. And so that also was a factor in thinking about this particular patient.
That's very interesting. So did the patient bring it up herself about the fatigue? And I'm curious if she connected the fatigue with the ITP.
Well, as my understanding of pathophysiology continues to evolve in understanding ITP and looking at complex immune-mediated dysregulation, I asked her, is she fatigued? And she shared that with me.
Very interesting. Thank you.
Let me share with you how I approach treatment for this patient. Her treatment history is as follows. We initiated dexamethasone 40 milligrams daily for 4 days. And my rationale for incorporating steroids was this is a standard frontline therapy in ITP, as you know, and it is part of guidelines. I also like pulse steroid in that you don't have to worry about a taper and the subsequent steroid related side effects that occur with a protracted taper. Her platelet count rose to 164,000, which held for 3 weeks. But then her platelet count again plummeted to 7. So when that occurred, I reinitiated the dexamethasone and added IVIG as well as L-Trombopag. The platelet count remained normal for 3 months. However, the challenge I was facing was titrating the L-Trombopag which ultimately had to be dosed at 12.5 milligrams every other day due to thrombocytosis. And as you know, there is a risk of thromboembolic complications with TPO-RA agonists.
So that's very interesting, Dr. Dean, about the patient's course and what happened with the therapies during the case. So tell us, what were the main medical concerns you had regarding the patient's clinical situation at that point in their case?
What was concerning was how can I eliminate thromboembolic complication as a risk for this patient?
Okay, very good. And then at that point, you selected your next therapy as WAYRILZ?
Yes, and the platelet count as I was titrating the L-thrombopag did decrease to 100,000. And in September of 2025, WAYRILZ 400 milligrams twice daily was initiated. And again, to reduce thromboembolic complications because the patient also was on estradiol.
Okay, very good. And so at that point, after you started WAYRILZ, what have been your clinical impressions thus far as the patient's status?
To date, the latest platelet count is 217,000, and the risk of thrombosis related to L-thrombopag has been eliminated. WAYRILZ has been tolerated well without any gastrointestinal side effects.
So very good, thank you. So what information did you consider in this patient's case to decide whether the patient was appropriate for treatment with WAYRILZ as their next therapy?
The indication for WAYRILZ is for treatment of adult patients with persistent or chronic immune thrombocytopenia who have had an insufficient response to a previous treatment. I would also like to highlight important safety information, and that is with regards to serious infections. An increased risk of serious infections, including bacterial, viral, or fungal, can occur in patients treated with Bruton tyrosine kinase inhibitors, including WAYRILZ. Fatal pneumonia occurred in one participant treated with WAYRILZ in the LUNA-3 trial. Other serious infections, one each, 0.8%, included COVID-19 infection, wound infection, urinary tract infection, and kidney abscess. Monitor patients for signs and symptoms of infection and treat appropriately. I want to tell you about how WAYRILZ targets complex immune dysregulation in ITP through Bruton tyrosine kinase inhibition. The Bruton tyrosine kinase is found in B cells and macrophages. In B cells, when WAYRILZ binds to the Bruton tyrosine kinase, that leads to inhibition of B cell activation and therefore reduction in autoantibody production. When WAYRILZ binds to the Bruton tyrosine kinase in macrophages, that leads to interruption of phagocytosis and therefore reduced destruction of platelets by macrophages. WAYRILZ, as a next generation Bruton tyrosine kinase inhibitor, has a tailored covalent and non-covalent binding region. This technological advance allows increased selectivity, and it does not affect normal platelet aggregation, which is important and does distinguish WAYRILZ in the class of Bruton tyrosine kinase inhibitors. Reversible binding allows for rapid drug clearance upon discontinuation without permanent modification of the Bruton tyrosine kinase or depletion of B cells.
Thank you very much for explaining that, Dr. Dean, especially as BTK inhibition is new within immune thrombocytopenia therapy. I think hematologists will really appreciate hearing that explanation.
Thank you, Dr. Mehta. I also want to share with you the LUNA-3 phase 3 trial that led to the approval of WAYRILZ by the FDA. The study design of LUNA-3, a phase 3 randomized double-blind placebo-controlled parallel group multi-center evaluation of the efficacy and safety of WAYRILZ 400 milligrams twice daily, for 24 weeks, followed by a 28-week open label extension in adults with persistent and chronic ITP, including those with insufficient response to corticosteroids and/or multiple treatments. The primary endpoint in this trial was durable response. How was durable response defined in this trial? It was defined as a platelet count greater than or equal to 50,000 for greater than or equal to 2/3 of at least 8 non-missing weekly scheduled platelet measurements during the last 12 weeks, including greater than or equal to 2 in the last 6 weeks in the absence of rescue therapy. As you can see on the bar graphs, the durable response for the WAYRILZ arm was 23%. The durable response for the placebo group was 0%. Approximately 30% of patients in the LUNA-3 trial had received 1 to 2 prior therapies.
Okay,
So
very good. Thank you for a review of the phase 3 trial data. And tell us more about any additional information regarding the patient's response rates.
yes, let's look at some post hoc analysis data on modified durable response. The modified durable response was defined using International Working Group Standard for Platelet Response as part of the criteria. The platelet count had to be greater than or equal to 30,000 and at least doubled from baseline. No bleeding, and the duration for greater than or equal to 50% of the assessments during the last 12 weeks of the double-blind period or last 16 weeks of the open-label period. As you can see in these bar graphs, in the double-blind period, the percent with modified durable response was 44% for those patients who had 1 to 2 prior therapies. And for all WAYRILZ patients, it was 34%. When we look at the double-blind plus the open-label periods, for those patients receiving 1 to 2 prior therapies, the percent modified durable response was 64%, and for all WAYRILZ patients, it was 50%. Now, there are limitations. This is a post hoc analysis, and it was not designed or powered to establish statistical significance. Results are descriptive only, and definitive conclusions cannot be made.
Thank you, Dr. Dean. Thanks for the data review. And what about any data regarding quality of life information that we have for WAYRILZ?
In LUNA-3, health-related quality of life analysis is available. This is across 10 domains, and as you can see, the overall health-related quality of life was 10.6 points in the WAYRILZ arm compared with 2.3 points in the placebo control. It is important to note that the information I'm sharing with you and with the audience on this slide is descriptive only. Definitive conclusions cannot be made. Patient-reported nature of the data may impact reliability of the findings.
Yeah, very interesting regarding the health-related quality of life. And how about the safety side of the coin as we treat our patients in real-world practice?
Yes, as you can see on this slide, the only grade 3 or higher adverse reaction was COVID-19, as this trial did accrue during the pandemic. But the most common adverse reactions were diarrhea and nausea, gastrointestinal side effects. And there was one patient who had a thromboembolic complication in the WAYRILZ arm, although it's important to note that this patient was on concomitant thrombopoietin receptor agonist therapy and had a history of comorbidities prior to study start. Also, adverse reactions resulting in discontinuation of WAYRILZ occurred in 4.5% of patients. The main reason of discontinuation was lack of platelet response, 41% in the WAYRILZ arm versus 80% in the placebo group. So that establishes WAYRILZ as a convenient oral treatment for ITP. The recommended dosage is 400 milligrams orally twice daily, with no dose adjustment required. It may be taken with or without food. However, if patients are experiencing gastrointestinal side effects, encourage them to take it with food. Take at the same time each day and swallow the tablets whole with water and do not cut, crush, or chew.
Dr. Dean, thank you greatly for your review of the patient's case, the clinical trial data, and your clinical perspectives. For the audience, remember that results may vary, and the results of one case study are not necessarily predictive of results in other cases. If you'd like to hear more about another patient of Dr. Dean's who was treated with WAYRILZ, please click on the link for a video after the additional important safety information. If you found this video to be helpful, please remember to like and share. So important safety information regarding WAYRILZ. Warnings and precautions include serious infections. An increased risk of serious infections, including bacterial, viral, or fungal, can occur in patients treated with Bruton's tyrosine kinase inhibitors, or BTK inhibitors, including WAYRILZ. In the LUNA-3 trial, fatal pneumonia occurred in one participant in the WAYRILZ group. Other serious infections, one each at 0.8%, included COVID-19 infection, wound infection, and one patient experienced urinary tract infection and kidney abscess. Monitor patients for signs and symptoms of infection and treat appropriately. Secondly, hepatotoxicity, including drug-induced liver injury, or DILI. Hepatotoxicity, including severe, life-threatening, and potentially fatal cases of DILI, can occur in patients treated with BTK inhibitors. Elevations of liver transaminases occurred with WAYRILZ in the ITP clinical trials and were generally mild to moderate in severity. Evaluate bilirubin and transaminases at baseline and is clinically indicated during treatment with WAYRILZ. For patients who develop abnormal liver tests after WAYRILZ, monitor more frequently. If DILI is suspected, withhold WAYRILZ. Upon confirmation of DILI, discontinue WAYRILZ. Thirdly, embryofetal toxicity. Based on findings from preliminary animal reproduction studies, WAYRILZ may cause fetal harm when administered to a pregnant woman. Verify pregnancy status of females of reproductive potential prior to initiating WAYRILZ treatment. Advise females of reproductive potential to use effective contraception while taking WAYRILZ and for 1 week after the final dose. Other adverse reactions include most common adverse reactions at an incidence of at least 10% were diarrhea, nausea, headache, abdominal pain, and COVID-19. Drug interactions include avoiding concomitant use of WAYRILZ with strong or moderate CYP3A inhibitors, which increases the risk of WAYRILZ adverse reactions. If short-term use of these inhibitors cannot be avoided, interrupt treatment with WAYRILZ. Avoid concomitant use of grapefruit, starfruit, and products containing these fruits, and Seville oranges with WAYRILZ. Avoid concomitant use with a strong or moderate CYP3A inducer, which may reduce WAYRILZ efficacy. Administer a dose of WAYRILZ at least 2 hours before administration of an antacid or histamine ACE2 receptor antagonist. Avoid concomitant use of proton pump inhibitors with WAYRILZ. Concomitant use of acid-reducing agents may reduce WAYRILZ efficacy. WAYRILZ is a moderate inhibitor of CYP3A and increases exposure of these substrates. Monitor for adverse reactions and consider dose adjustment of the CYP3A substrate. WAYRILZ is an inhibitor of PGP, BCRP, and OATP1B in vitro. The effective concomitant use of WAYRILZ with OATP1B and BCRP substrates has not been established in clinical studies. Monitor for adverse reactions of the concurrently administered PGP, BCRP, or OATP1B substrate more frequently, where minimal substrate concentration changes may lead to serious adverse reactions. Regarding use in specific populations, for patients who may be lactating, for lactation, due to the potential for adverse reactions in a breastfed child from WAYRILZ, advise lactating women not to breastfeed while taking WAYRILZ and for at least 1 day after the final dose. Hepatic impairment. Avoid administration of WAYRILZ in patients with moderate or severe hepatic impairment, such as Child-Pugh class B or C. Renal impairment. Avoid use in patients with severe renal impairment. For more information, please visit the website www.wayrilz.com/HCP.